Are we?
Yeah,
Yeah,
ma'am.
now we are. Yeah. Good evening, everyone. So, this is a very interesting topic which was requested by a lot of people. I remember when I learned TLH 7 years back, it was my dream when I started doing laparoscopy to do TLH in 40 minutes without needing any help independently. So, this is a milestone. Every guy. Stop laughing. I know it is very juvenile for you and very what a joke, but for a lot of people, it is a milestone in their laparoscopic career to do TLH independently and also confidently without having any complications because though as gynecologists we deal with only uterus, fallopian tubes, and ovaries, but many a times we find it a big struggle when the anatomy is distorted or when the size of the uterus is altered, and especially when we are not very confident of the steps of hysterectomy. So, everybody's learning curve is steep except for some abnormal people. Uh, so, here we are to learn the tips and tricks from 45 minutes, which I thought was the gold standard to do a TLH, and the fastest I had seen when I was newly learning was around 15 minutes to now, where I have seen Dr. Jay Mehta operate TLH in 5 to 6 minutes. I mean, it is uh, a super speed TLH that he does. So this is something which I think he has mastered because now the perfection is already there and he has to focus only on the speed. So many people ask whether speed is really important when we are operating. Isn't the patient safety more important? So he has already attained that perfection. So speed is definitely not a factor, which time and again we have explained in so many groups. But this is not about the speed that we are talking here today. We are talking about the steps and also the safety in doing TLH. So though he does in 5 minutes, I have seen that hardly there are any complications in the TLH that he does. Even previous three sections, previous 2 times operated, the endometriosis and all that. So this is something as a basic steps that we would like to tell, not focusing much on the speed, but on the safety standard technique. So TLH is something which many youngsters want to learn, and they spend so much time and so much effort, and they keep, I think, hustling from one technique to another. But I have seen Dr. J do the same steps every time it is the same steps. So today will be something like a basic class, which I want everybody to kind of understand what he's trying to say. Listen to the class 2 3 times so that you can go back and replicate it in your cases. And I think I can vouch that I have learned so many things when I have observed him operating minutely. So this is something which is going to be a very interesting class and very worthy class for all of you. Yeah, over to you.
So you just said that you've learned many things by observing me minutely, right? So can you tell me the top two things, madam, which you would have learned?
One is traction, counter traction. Okay, the traction is something which I have, I mean, I cannot say that how important it is, because the amount of safety that it gives and also the speed it gives in coagulating and cutting is something which is, I don't think it can match to any other step. That is something which I have seen you in every procedure that you do it. And second thing, what I have seen you is like you follow the same steps every time without changing much. I mean, I have not seen you fiddle around like whether to do this one, that one day you do the right first, left first, whatever. I mean, I have seen you do it the same way all the time. And also, I have seen you doing it so confidently all the time. I mean, not even once I have seen you faltering in terms of like finding out. Even this time when you operated here, we had we had a patient where it was abandoned almost like 3 times, and you had to operate, and the bowel was cut all at almost like 4 to 5 areas. But without even like, I think, getting disturbed, you finish the entire procedure and we discharge that patient in what, like 48 hours. So I mean, this is something which I think is not very normal. But at the same time, by observing you and also by seeing your steps and listening to what you have to say practically, will give us a lot of like insights as to how we can be safe yet be aggressive in terms of like doing cases.
So first thing, which before I start the video is only 5 minutes. So the first thing which I want to tell everybody, do not get carried away by anything which says that, only a particular instrument is safe when it comes to doing pelvic surgery or TLH. Okay. You would have seen me using a basic Indian bipolar sharer. That is basically what I can afford. Okay. And that is something which I use repeatedly in the surgeries. Right. Second, I thought Shilpa madam would mention this, but then I think she would have observed, but it has slipped out of her mind. I almost never use any special manipulator. Never, never. I am not trained in that manner. I just don't understand how to use a manipulator. Okay. So I don't use a manipulator when it comes to doing a TLH. I do not require a manipulator when it comes to opening the vault, because predominantly my training is through a gynec cancer surgeon as a professor. And I have simply learn to do a hysterectomy without touching the uterus all the time. Okay. So that is something which I have learned very, very early in my career. But if in case anybody of you loves to use the manipulator, or is using the manipulator, or is comfortable with the manipulator, or is comfortable with myoma screw as traction, kindly do that. You need not think that, okay, Jay told this, so that is why you should do this. Absolutely no such thing in life. All right. Now, third, again, I think this is something which is very different when it comes to my surgery, so I'm addressing it first. See, I do not follow ipsilateral or contralateral. Okay, I don't have that technique. I do not do ipsilateral surgery or contralateral surgery. For me, it is simply surgery. So I go through the middle port. Okay. And everything which I do is basically done by me through the middle port. I do not have that type of system only, where I think I'm more comfortable contralateral, I think I'm more comfortable ipsilateral. There is no such thing. You can give me ipsilateral and I'm equally comfortable. You can give me contralateral, I'm equally comfortable. You can give me the middle port and I'm equally comfortable. Okay. But if in case you are somebody who thinks that, okay, I am more comfortable doing ipsilateral hysterectomy, then you do it ipsilateral. If you think that you are more comfortable doing contralateral hysterectomy, then you do it contralateral. For God's sake, do not let it interfere in your brain as to which type of hysterectomy you should be doing. In which patient, or should you be changing, or should you only be specializing in one type of hysterectomy? Because many a time, see, I hardly get to do a basic hysterectomy. Many a times the type of hysterectomies which I am doing and I am showing is when one side there is a colostomy and second side I am doing a hysterectomy, right? So I am doing those hysterectomies in very, very, very simple ipsilateral techniques and ipsilateral maneuvers. That time I can't even put a port along the contralateral or in the middle port, and the hysterectomy still gets achieved, isn't it? So just make sure and just keep it in your head that every anatomical variation which presents in a uterus is simply achievable very, very straightforwardly. You should not be worried. Second, I always put the trocar in the supraumbilical region only. I never go umbilical. The only time I have an umbilical trocar is for a diagnostic histolaparoscopy, okay, where the uterus is freely mobile. Otherwise, I don't do it. The always the port is supraumbilical only, and that is a take-home point according to me. Always my port position is different. Matlab, I will never have that two finger above anterior superior iliac spine, mid clavicular line, lateral port. No, I will make the lateral port adjustment based on how the patient's abdomen is. And that I think Shilpa madam would have seen many, many, many times. Sometimes it is 2 centimeters above, sometimes it is below, sometimes it is below, above, middle, contralateral, lateral, whatever. you should be able to achieve triangulation. And if you are able to achieve triangulation in your surgery, that means life is good. You should not be worried about it. So that is a very important take home point, because I want all of you to take home that it is completely fine and it is completely normal to be yourself when you are doing this surgery. You need not try to be Jay Mehta or Shilpa GB or Sachin Dalal or Aarti Deendayal. That is simply not required. You need to be just yourself. If you are yourself, you will achieve this surgery very, very beautifully, is what I think. I will actually try to go to the screen sharing. I just hope it is visible.
Yeah.
Right. So so if you see, this was a basic TLH. Now I'll just pause here. The traction which I have given, no? Can you see? The traction is on the fallopian tube. Did you see?
Yeah.
The traction is on the fallopian tube, and see where it is being pulled. Always, if I'm operating on the right side, you pull towards the left shoulder of the patient. Can you see this?
Mm.
See, now look. Fallopian tube pulled towards the left shoulder of the patient. है ना?
Yeah.
What is the second thing? I have holded on. See this. I am now holded on to the fallopian tube, and the cut which I am doing is going to be in the middle of the round ligament. Do not cut flush to the uterus. Huh? People have this. People have this sort of teaching and habit that you should always kiss the uterus when you are doing hysterectomy. Correct? No, nothing like that. Round ligament cut is lateral, and see, immediately broad ligament opens. Immediate, you don't have to do anything. Immediate broad ligament has got opened completely. Go to the posterior leaf, divide the posterior leaf. Okay, go to the anterior leaf, cut the anterior leaf. These are all standard, very, very, very standard, matlab very, very, very standard steps. Cut the anterior leaf and just push it down. Anterior leaf to be cut, pushed it down. Okay, now when you just push it down, automatically the bladder has gone down. You don't even have to do anything. This is basically a case where there is some endometriosis here there at the uterosacral, which we did recently, which is why I have just posted this case. But remember one thing, in very, very quick time you will expose the blood vessels, and once you expose the blood vessels, see the coagulation always occurs perpendicular to the blood vessel. This is the exact time which you will take to expose of the blood vessels. Okay, exact time is this much. See this. So that means from the start of the hysterectomy, 1 minute 30 seconds. This is live. Huh? So this is in 1 minute 30 seconds. You have gone to the blood vessels and you have coagulated. That means 50% of the uterine blood flow is gone. Okay, 50% is gone here. Just see. Now after you have done, traction changes immediately. Another side we go. See, first we went on to the right side. Now we are going on to the left side. Same fallopian tube, because you will have to do salpingectomy. Preservation of the ovary is of course very, very important, as we are all aware. Okay, you go to the adnexa you will cut, like how you will cut, in any other situation. The instrument which I am using is a bipolar shearer. Just press onto the pedal and the shearer will simply cut through it. And again you reach the round ligament. Now when you reach the round ligament, see that there is endometriosis there downstairs at the uterosacral. Nahi? So when you reach the round ligament, see round ligament also go lateral. Cut lateral at the round ligament. Once you cut lateral, automatically see anterior fold opened. You don't have to do anything. Anterior fold opened, posterior fold cut. You will reach straight to the uterosacrals. Okay. So again, see how much time it has taken for anybody in a live. It will take how much? Just see this. So it has taken another 45 seconds. In 45 seconds, you have reached the vessels onto the opposite side without doing anything. No pushing, pulling, jerking, pulling, killing, changing instruments, nothing. Instruments are never changed. There goes the utrovesical fold, push down. Don't have to separate, pull, kill, nothing. See that blood vessels are beautifully exposed right in front of you. The bladder is doing nothing. Bladder is like an obedient husband, simply going where the wife is pushing. See that? It will just keep on going down, 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 down. Nothing will happen, and the bladder is completely pushed down. Bladder pushing down time is total 20 seconds. Okay. In any hysterectomy, it will take you, even if it is previous 2 section, 3 section, 5 section, 20 section, whatever it is, the bladder pushing down time is maximum going to be 1 minute. Okay. So after you push the bladder down, see that bladder is nice, clean, gone down. Then once the bladder is down, automatically you will go on to the blood vessels. hold on to the blood vessels and simply coagulate perpendicular to the blood vessels. Kindly do not make that mistake ever in your life of coagulating horizontal, vertical, nothing. Perpendicular. See that that is how you holding and that is how you coagulate. Hold, coagulate, hold, coagulate. I'm not changing my instrument because I'm very, very comfortable coagulating vasculature of any size with the sharer. But if you are not used to it, then you can use a bipolar here. Okay. That is another take home point. Do not get carried away that acha chalo tomorrow morning we will use the sharer. Remember, I have a very high turnover time of a sharer. Okay, I change the sharer every 4 cases. People will use the same sharer for 40 cases. So the effect of the sharer which I get in 4 cases, you will not be able to get in your 35th case. And then you will think that, Array, why is the sharer working so nicely in his hands? There's nothing like that. Huh? I change it very frequently. So both sides uterine is cut already. Everything devascularized. See that there is a bowel adhesion there. Can you see? Downstairs. See, bowel adhesion is there. Nahi? Pull the bowel, cut. I mean, cut means don't cut the bowel. Just cut that fascia where it is adherent and see bowel is gone down. Tata. So once the bowel goes down, nothing. That part is also done. Then the only thing which is remaining for you as a surgeon to achieve is opening of the vault. All right. Now I understand vault opening is something which some people feel that they have to pass an instrument from below this, that. I'll show you a very simple trick in which you can open the vault. Remember where this uterosacral is. Just besides the uterosacral is the vault. So cut the uterosacral and automatically you will be very, very close to the vault. This is all that bowel part which I'm pushing down, guys. This will again, as I told you, finish in maybe 2 minutes at max. So once you cut this, see that? That is that uterosacral cut. See this. This is that uterosacral. Macken rods. Anterior is Macken rods. And behind in the posterior is uterosacral. You see a beautiful giveaway. See that. Saw that giveaway?
Yeah.
That giveaway is the uterosacral. So the minute you cut the uterosacral, right underneath that is the vagina. No need to worry, give proper traction and just open up the vagina. Okay. This is how I do. As I said, if you are not confident, you can use colpotomizer, you can use whatever, and you can open. I'll just show it to you. See this. This is where the vault will open just besides the uterosacral. Just give this proper traction, okay? Even in these big uterus, no? This 12 weeks, 13 weeks, 15 weeks uterus, no? Just remember to give a very good traction. Always the mistake which we make, as Shilpa madam mentioned in her first line itself, is to not give traction. We are very carried away by giving incorrect traction. Never do that. In fact, it should be the exact opposite. See, once the uterine is taken out, see that uterosacral gone. Once the uterosacral is gone, automatically the uterus will get pulled up. And once it gets pulled up, please give correct traction and simply open up the cervico-vaginal fascia, because it will any which ways open up. There is nothing out there for it to not open up. So I'll just go to the uterus there. See that? That is your entire cervico-vaginal fascia. Elongated cervix is present in this particular lady. Every attachment between the cervix and the vagina has been severed off. See, I am palpating that. Can you see? I was palpating onto the cervix. So palpate. Learn to palpate. It will take you some time. It will not, see that palpation will come after around 20 cases. See, you are palpating. Acha, where is your uterus? Where is cervix? Where is vagina? You will start to get a feel of it very beautifully. And once you are doing enough number of cases, your palpatory findings will become very, very good. And you will be able to palpate and tell somebody, ki, Acha, this is the vagina. Even if they close your eyes, no? And they just give you the instruments, no? You will palpate the cervix. You will palpate the vagina and you will say, ki, Acha, this is the vagina. Like that, practice will happen. Like that, cases will become streamlined for you. And once the cases become streamlined for you like that, simply you will go there and no manipulation, nothing fucking, nothing doing. You will just go and you will open the vault. When you open the vault there, once the vault is opened, life is like very, very simple, as you can see. Once the vault is opened up, the whole uterus, you just have to go and hold the cervix. Lot of times this question has been asked, Are, how is it that your vault opened up and air leak did not happen? That is because I am using a menstrual cup in the vagina. Okay. I mean, God bless that person who invented the menstrual cup. Forget whatever it does to menstrual people. What it does is excellent in hysterectomy. It prevents loss of pneumoperitoneum. See that? I am holding on to the cervix, flush holding on to the cervix, and cutting it flush to the vagina. No loss of vaginal length ever happens in this situation at all to the patient. Remember one more important thing. You will rarely see me changing instruments in a surgery. I think Shilpa madam can also vouch for that. Once I start the surgery, my instruments, the only time I will change is, let's say if I want to get a suction inside for doing some suction. I'm very casual about suction also. I don't do suction so frequently inside the surgical field. And remember, with simple techniques like this, with simple standardization like this, you will be able to make sure that your surgeries are finishing very nicely. Now, before I actually conclude, I wanted to draw and show you one more last thing which people have asked about many times. So I just thought I should show it to you. If this is the abdomen, okay, this is the abdomen and this is the umbilicus for that lady. Okay, I will normally put my primary trocar here. This is my 10 mm trocar. Okay, I will put the 5 mm here. This is my 5 mm trocar lateral. I will put the middle trocar here, slightly below. Okay, and the other 5 mm if required is here. These both guys are going to be in the same line. This trocar is going to be slightly below, maybe 1 to 2 finger breadths below. Okay. And the supraumbilical trocar is going to be supraumbilical. This is my standard port positioning. Never in my life I will change this port positioning unless I have to do something about it. Like never it will change. Never is the word, huh? Never. So just keep that in mind whenever I am doing these surgeries. It never ever changes for me. Okay. So I think that is something which is
Yeah.
probably
It
important.
yeah, this was quite nice because I think you told all the relevant points and the steps that you have described in detail. So let us today's class, as I told, it's a basic class where we are dealing with a normal sized uterus or just slightly above normal sized
Yeah.
uterus.
10
So
weeks, up to 10 weeks.
up to 10 weeks, I think this holds good, whatever you have shown. So the first step that you did, like, I mean, the fallopian tube, which you gave traction, why is it that, like, in our hands, it just comes on to our instrument?
That is because you don't love it enough. And second, you don't see, you try to grasp it, madam.
Yeah.
When you have that ratchet, it is into three. You have crush, you have hold, and you have sort of clamp. Okay, so basically it is hold, clamp, and crush. 98% people want to crush it, understanding? And we want to hold it. There is a very much big difference in holding and crushing an instrument. What will happen is when you try to crush it and pull, no, it's like how you want to throw me out of Bangalore, how much vigorosity you are using in throwing me out. Same vigorously you are pulling the tube towards you. So what will that tube do, madam? It will also break only, no?
Yeah. So instead of that, I see a lot of people giving traction with the round ligament, which is more sturdier, I feel.
Yes,
So,
yes. That is also good to give traction with the round ligament. But remember, fallopian tube is a mobile structure.
yes.
Fallopian tube has only one attachment, that is towards the uterus. So you need to, in order to do a salpingectomy, you need to give traction to the tube. You can't give
Yes.
traction to the round
Wrong
ligament.
document. I totally agree. So the second step, which I actually learned from seeing your surgeries, both online and offline, was that, like, how you do the bladder dissection.
Yeah.
So we are so scared that we are always, like, going so close to the uterus, actually avoiding that plane between the bladder and the cervix, and we try to, like, coagulate, and we miss out on the plane, whereas, like, you completely give the traction holding the entire bladder, and then you start dissecting and you go into that right plane where we hardly see any bleeding, and it opens up beautifully because of the gas inside.
Yeah.
So in this, I mean, what have you seen? Because I know that you see a lot of surgeries which have been done previously, and then you have redone it for some reason or the other. So what do you think, like, the bladder dissection has to be? Because this itself is a biggest challenge when we are actually learning. See, the first step is doing the adnexa, which we kind of, like, master it very easily. But and then comes the bladder dissection, where many a times we get stuck there for quite a few weeks or months, and then we master that, and then we go for the last step, that is the uterosacrals and vault opening. So in your case, bladder dissection, I know you said it takes 20 seconds, even in a case of previous 5 sections, 20 sections. But after, like, one section, we are so cautious when we think of doing the bladder dissection.
That is because of way in which our training is, madam. We are. It is nothing to do with bladder and the uterus. The bladder does not know how many sections the uterus underwent. Understanding? It is just in our mind that we begin to believe that if there are two sections, that means bladder is going to be adherent here, there, whatever. See, try and understand one simple concept. Okay, the bladder does not go and get adherent on a normal uterus. The bladder will go and get adherent on a scarred uterus. So the bladder will go and get adhere where the scar is, that is in the lower segment, or if it is a classical cesarean, then throughout that, throughout that horizontal line. But the bladder only gets adherent to that scar site. Understanding? So you just have to be careful of the bladder which is adherent on that scar. The bladder underneath that is going to be free only, no? Any which
Yeah.
ways.
Yeah.
And I think the other thing which you mentioned, no, that you are, as people are taught to cut close to the uterus. That is a very wrong concept. The space between the bladder and the uterus is a utrovesical space. That is how it is labeled. Any space is an avascular region in most of the times. That is the reason why we open in an avascular plane most of the times. All you have to do is give correct traction. And as long as you are giving correct traction, life is simple. You really don't have to worry. I've seen so many people arguing, Arey, bladder is here, ureter must be pulled up. Arey, where is ureter here? Ureter is in the retroperitoneum. Okay. Retroperitoneal ureter, how will you go and injure in bladder dissection? It is not possible only to injure. Correct. The only time you will injure is probably if you are doing uterine at origin, or you are doing uterosacral when ureter is very close by and you have not dissected it. But usually, if your training is good and if you are dissecting the ureter time and again, time and again, time and again, you will dissect the ureter and only then do the uterosacrals. I personally do not think, uh, I personally do not think that is something which you should be worried about.
Yeah, correct. So I think we'll finish this class. We'll talk about vault opening and uterosacral dissection a little more in detail because lots of queries have been raised in those steps. So if you
Right.
don't mind, this will be the first class. Then we'll do the next class as that one, and then probably previous section, large uterus, distorted anatomy, things like that.
Okay,
Thank
done.
you. Yeah, thank you so much, everyone, for joining us on a weekday at 10 o'clock in the night with a short notice. And I thank everyone for their precious time. I thank Dr. Jay for his time with his broken toe. He is here with so much of pain and misery to teach us all about removing the uterus. Thank you so much.
1 minute, guys.